Great. Thank you all for joining us for today's webinar. We have the honor of having two special guests talking a little bit about remote monitoring research and some of what they're working on at the University of Mississippi Medical Center. So I'll introduce our speakers quick and then we'll jump right in. First, we have Carly Brown, a clinical pharmacist specializing in telehealth-enabled chronic disease management at UMMC's Center for Telehealth and Emerging Technologies. Dr. Brown serves as principal investigator on a HRSA-funded National Telehealth Centers of Excellence Award evaluating the clinical effectiveness and sustainability of telehealth-enabled chronic disease programs. We are also joined by Kyle Brewer, who is the telehealth administrator for the University of Mississippi Medical Center. Kyle is a distinguished healthcare professional with over 20 years of experience as an entrepreneur, innovation leader, executive consultant, and administrator. Thank you both so much for joining. I'll turn it over to you all.
Awesome. Thanks, Lydia. Let me go ahead and share my slides and I'll let you confirm and you see them. Okay, are you seeing my slides?
Looks great.
Awesome. Thank you. Well, good afternoon, everyone, and thank you for joining today. As Lydia said, I'm Carly Brown, and I'm a clinical pharmacist with UMC's Center for Telehealth and Emerging Technologies. And I'll be joined later in the presentation by Kyle Brewer, who's our telehealth administrator. So for today, we'll just walk through how remote patient monitoring, or RPM, has evolved in a real-world clinical practice and what the current evidence shows about its effectiveness and where the biggest opportunities are for us to move forward with remote patient monitoring. So our goal for today is really just to share both some of our operational lessons and some of our clinical outcomes as well from our experience in building and scaling RPM programs across several different chronic disease states. The research work that we will showcase later on in the presentation is supported through our HRSA Telehealth Center of Excellence grant. So again, today we'll focus on four main objectives. First, we'll briefly describe how our RPM infrastructure has evolved over time and what it takes to operationalize these programs. Second, we'll compare different disease-specific RPM care models, particularly separating those out into pharmacist-integrated and nurse-driven models. And then third, we'll review some of the clinical and utilization outcomes we've observed across our programs. And finally, wrap up with some workforce integration and sustainability, which are of increasing importance. So to understand why RPM has become such an important tool in Mississippi, I think it helps to understand the healthcare landscape in which we operate in. If you're unfamiliar with the state of Mississippi, we certainly have a high burden of chronic disease, as many of the states across the United States tend to have. But at the same time, many communities, particularly rural areas, face limited access to specialty care. And so at the University of Mississippi Medical Center, we are the state's only academic medical center and also serve as a major referral hub and provide care to patients across the entire state. So for those reasons, telehealth and RPM have allowed us to extend that specialty expertise across the entire state with limited access to consistent chronic disease management. So a little bit about our RPM program. It did launch in the early 2010s and initially focused on diabetes, which has certainly expanded over time. We started out with a pilot project in the rural Mississippi Delta, knowing that if RPM can work in the Mississippi Delta, then it can essentially work anywhere. And a real major turning point in our program was integrating pharmacists into the care model, which really changed how we approached chronic disease management and allowed for more proactive and timely management for our patients. So our RPM program relies on several key infrastructure components, and I want to walk through that a little bit before we get to our outcomes so you can better understand those as well. So as many programs do, we have connected devices that are linked with the electronic healthcare record. We have daily monitoring and protocol-driven alerts. However, I think the value of RPM depends on how that data is used to drive clinical decision making. So on the clinical side, we have nurses that are monitoring incoming biometric data and responding to those alerts using established safety protocols. Patient engagement is also a major focus, so the team routinely communicates with patients about their readings, their symptoms, and treatment plans. And then in programs where the pharmacy team is integrated, we also conduct protocol driven medication titration under collaborative practice agreements with our specialty physicians. One challenge in RPM is the variability in how programs are designed. And so we've really worked to standardize our approach into two scalable care models. And I've broken that down into two different types of models. First, a pharmacist-integrated model, and then also a nurse-driven model. And these two models allow us to tailor interventions based on patient needs and also the disease complexity. So first, the pharmacist-integrated model focuses on our chronic conditions such as diabetes, hypertension, COPD, and we have the pharmacy team actively managing medications under a protocol. Whereas the nurse-driven model, the nurses are still monitoring the alerts, but they're escalating to concerns to specialty providers when needed. And so both of these models rely on the same monitoring infrastructure, but the care team structure differs depending on the clinical needs of the patient population being monitored. These programs operate through clearly defined workflows, which has been critical to really maintaining consistency and scalability across programs. And so, although these two workflows are very similar, I do want to point out two key differences. In both models, we have the same incoming patient data that's generating alerts based on those predetermined thresholds. And of course, we have the monitoring team in place that's evaluating those alerts and communicating with the patient to determine further needs. However, in the pharmacist integrated model, again, our pharmacy team is playing an active role in medication optimization. And so when alerts or trends suggest that a patient's disease is not well controlled, then the pharmacist can call the patient to assess adherence, evaluate their therapy effectiveness, and then make those protocol-driven medication adjustments. And so this model really allows us to address those medication-related issues quickly without waiting for a traditional clinic visit. And then, whereas in contrast, the nurse-driven model focuses on monitoring and escalation. So again, nurses are reviewing the daily biometric data, assessing alerts, and then if readings exceed those established thresholds, then they can report back to the specialty provider. And so this approach works well for conditions where rapid recognition of clinical deterioration is really our primary goal. This slide just shows a quick example of how our team responds to a critical blood pressure alert. So putting it into practice a little bit to make a little bit more sense. If a patient records an elevated blood pressure reading, then the nurse would immediately contact the patient and follow a safety protocol to take time to assess symptoms and potential causes of the elevation. If repeated unexplained critical readings continue to occur and we have more of a trend at this point, then the nurse would escalate to the pharmacist for a potential adjustment in the patient's medications. And so, of course, the referring provider is also notified so the broader care team remains informed. So everybody remains on the same page as far as caring for the patient. So with that context, I'd like to briefly review some of the clinical and utilization outcomes that we've observed across several of our RPM programs. First, our hypertension RPM program, where we evaluated the implementation of a pharmacist-led monitoring program for patients with uncontrolled hypertension, so meaning a blood pressure greater than 130/80. We had over 200 patients complete the program between 2018 and 2022. And we found that patients enrolled in RPM experienced significantly greater reductions in both systolic and diastolic blood pressure compared with matched control patients that were receiving usual in clinic care only. In our diabetes RPM program, preliminary data suggests an average hemoglobin A1C reduction of nearly 2 percentage points, which is clinically meaningful to many of our patients. We've also found that patients that are more engaged in the program and are not discontinuing the program early due to noncompliance or other factors and are actually meeting their goals and completing the program, those patients have seen reductions of up to 3% or over 3% on average for their A1C. Next, in our COPD program, we evaluated the impact of daily biometric and symptom monitoring with protocol-driven escalation. So among patients enrolled between 2023 and 2025, we observed a 68% reduction in acute care utilization compared with the year prior to enrollment. While understandably this is a relatively small cohort, the results certainly highlight the potential for RPM to detect exacerbations earlier and intervene before hospitalization becomes necessary. Lastly, we've also implemented a nurse-led RPM program for patients with congestive heart failure following either hospital discharge or maybe at time of ambulatory visit. So among patients who are completing onboarding, we've observed nearly a 50% reduction in hospital days per year during program participation. Though likely underestimated based on initial estimated hospitalization cost, this translates to more than $11,000 in potential cost savings per patient annually. An important component of sustaining RPM programs is also workforce integration. So as programs grow, relying solely on existing clinical staff can become challenging. And so we've addressed this by developing a structured telehealth preceptor model that incorporates pharmacy trainees directly into RPM workflows. So this model embeds both pharmacy residents and student pharmacists directly into the RPM operations. Between 2021 and 2025, trainees contributed roughly 8,000 hours of service to RPM programs. So learners are able to actively participate in patient outreach, monitoring activities, and medication assessments under supervision. And not only has this approach allowed us to expand our own internal program capacity, but has certainly created valuable training opportunities for our learners as well. They're able to gain real-world experience with digital health technologies and chronic disease management. At the same time, the health system benefits from additional workforce capacity and strong program evaluations. Through these programs, we've identified several key lessons. First, surveillance alone often has limited impact if it's not paired with meaningful clinical intervention. Secondly, medication optimization is a major driver of improved outcomes, which is why pharmacist integration has been so valuable in several of our programs. We've also learned that clearly defined workflows and team roles are essential for scalability, and integrating trainees or additional workforce models can significantly expand program capacity without dramatically increasing the cost. So at this point, I will transition to Kyle, who will discuss how broader healthcare payment reforms, particularly that shift from fee-for-service to a value-based care model, and how those are influencing the future sustainability of RPM programs.
All right, thanks, Carly. So I'm gonna shift a little bit from our own experience and what the things that we're doing here at UMMC and talk a little bit more about the industry at large and where things are going. I want to start off by just sharing with the group an important stat that I found recently that from the CDC that 90% of all U.S. healthcare spending is on chronic disease and mental health. So that means that almost everything we spend in healthcare is not on emergencies and surgeries. It's on longitudinal predictive conditions like diabetes, hypertension, heart failure, COPD, depression. Um, these things that can easily be monitored and that we can expect what's going to happen with these patients. Um, and we've really built a system that is more reactive and really it incentivizes more cost and more activity for healthcare organizations to spend to help try to take care of patients with these chronic conditions. So that's why we find ourselves in that high cost situation. And that's what's changing. So CMS is pushing the industry away from that traditional fee-for-service model that encourages volume and more towards value-based care models that are going to encourage better patient outcomes. So I'm going to highlight a few of the differences between these services, and then I'll focus more on some of the more value-based options and then how we can prepare for them. Next slide. So we're going to look at remote patient monitoring, chronic care management, APCM, advanced primary care management, and then the new CMS access model that's come out recently. And so the RPM and chronic care management are the more traditional models that we see out there that most people are using. And they're going to pay for specific time and tasks that people spend with patients. And so the biggest differentiator here between these models is really about the payment structure and the outcomes that are expected. So we're going to lump in the RPM and CCM into the more traditional models. And then we're going to show how APCM is the new model that is relatively new that has come out that offers more of a bundled per patient per month payment model. And that is based on how many chronic conditions a patient has or the complexity of the patient. And so the patients could even have zero chronic conditions. And so it's really based on you're getting payments based on the complexity of that patient. And then as we look at the access model that has come out, that offers base pay, but then also outcome aligned payments that are based on the type of chronic condition. And then there's certain reporting requirements that are required outside of that for or within that program to show the clinical value that is being delivered for your patient population. So for the APCM and access models, it's up to the organization to deliver effective services to improve the care while still controlling the cost. Really, so this is a shift in models that CMS is pushing, and it's intended to incentivize these organizations to provide more efficient care to patients and really drive those outcomes. And as of really 2 days ago, I believe, I'll also add that CMS recently announced that the first 150 organizations that are now enrolled in the access program. And so you'll see a lot of, I think we're going to see a lot more activity in that space now that we've actually identified those organizations, and it's going to be rolling. So there's going to be more organizations adding on to that over the next couple of years or so. So next slide. All right, so how do we adapt? How do we prepare for this? So one important change is that the APCM and access models are going to encourage a lower level of clinical engagement across a broader patient population. So I think of it as you're going to be able to cast the larger net to include more patients that may not necessarily identify as high risk. So traditionally, again, with the RPM models, you have a lot of high risk patients that that you're really trying to tackle their conditions and their values, their measurements, and then these programs will include those, but then also really reduce that threshold and allow your clinical team to actually provide more preventative and proactive care to people who may not meet those same traditional thresholds. So in order to adapt to that shift, risk stratification is going to be important. So, your high risk, uncontrolled patients on your program is going to have different needs than the engaged pre-diabetic patient who is proactively trying to improve their health. And for your lower risk patients, you may want to automate as much as possible of the administrative type functions as you can. But this is going to require better software to provide a higher level of engagement and possibly the use of some AI to help really prompt patients across a larger population to be able to get the care that they need so that your clinical team can focus on the ones that really need that intervention and really need that level of clinical expertise so that your clinical team can operate at the level of their license. And so, I think that's kind of representative of some of the things that Carly just talked about with how we have different different workflows that include different members of the team based on the conditions that our patients are facing. So if they need that higher level of medication management that our pharmacists can provide, then we're stratifying them and we're putting them into that bucket and they're getting that level of care. And I think that's going to be key for us as we try to look at these new models that are going to open up the thresholds a little bit but we want to still maintain our quality and ensure that we're getting good outcomes out of these programs. So that's just a high level where we're going, where we see the industry going and some of the things that we can think about as to prepare. But at the end of the day, the expectation is that this change is going to help deliver more efficient care and also help control the cost of care to the patients at the right time and at the right place. Thanks, Carly. Back to you.
All right, thanks, Kyle. And really just building upon what Kyle just said there, you kind of took the words right out of my mouth. But certainly we know that our models and our workflows and our programs, they're working well. We're getting good clinical outcomes, but how can we be more efficient? How can we incorporate more patients into our programs and provide a higher level of care and in the same spot, a more specialized level of care when needed as well? And so some future directions that we're looking at is, right now we have several different programs and we're following these patients kind of in these siloed programs, knowing that most of our patients have multiple chronic conditions. So really expanding that and taking care of the patient as a whole and treating their multiple chronic conditions at the same time, or providing them education on how to treat those multiple conditions, while also integrating additional telehealth services. So I think patients' mental health, nutrition services are certainly important in helping patients to care for their chronic diseases as well. And so future research in these areas, not only looking more at the long-term utilization and outcomes for our RPM programs, but also looking at those workforce strategies to support these scalable RPM programs. So reevaluating our workflows and team members that we have, while also incorporating the use of those AI-enabled tools, as Kyle mentioned, to help with risk stratification and prioritizing those clinical interventions. And then, of course, the financial sustainability of it all and that value-based care impact as well. So from there, that concludes our presentation, but we are more than happy to answer any questions that anyone may have.
Thank you both so much. If you have a question, you're welcome to either unmute and ask directly, or feel free to use the chat as well.
I have a question. My name is Casey Piddock, and so two questions. First, how many patients do you serve typically, in any given day, any given month with RPM in general? And then second question, how do you view the reimbursement plan for the access program? I know two very separate questions, but those are my two questions. Thank you.
Kyle, if you want me to answer the first one, I'll hand it to you for the second one.
I'll take it if you want to. So it varies, I think, and Carly, you can add on if you want to, but it varies as far as our numbers go. I mean, it's several hundreds. Depending on we have several different direct partnerships that we provide care to, but then we also have some grant related efforts that are kind of revolving. So it's kind of a shifting number constantly. As far as access, we actually are not an access member. We did not actually sign up for that, primarily due to some of the restrictions around. As an academic medical center, it would have been challenging for us if we were to see the patients within our own organization. There's actually a restriction to where the PCP would not have been able to bill any E&M coding for that patient during that duration. And so I think that really put a lot of healthcare systems out of the running there for that one. So I looked at the list of, I think there's like 150 organizations that signed up for access at this point, or that were awarded enrollment to the program. And I think you saw or at least I think really kind of what I was looking at from skimming the list is it was organizations that were primarily around those specific types of conditions and that weren't really a larger part of a larger organization. So some of the restrictions that CMS put in there would not have impacted them as much as it would have us. So that's really kind of why we felt we found ourselves outside of that group there.
Yeah, I got it. It's just so we're at the infrastructure supply level of RPM technology, devices, platforms, private networks, all kinds of good stuff. So we're very intimately involved in the RPM industry, and we see the access program as it's nice, but the reimbursement is a challenge, frankly. And so I think the government's struggling to sign up as many as they'd had hoped to. Like they extended the deadline to May 15th. I just saw that. So, they'll get the message pretty quickly that they got to tweak their reimbursement a little bit because it's just, it's hard to survive with that kind of reimbursement. So actually, if I could pile on one more question, the Rural Health Initiative, right? Now to me, that's a game changer for the industry, for Mississippi and other states. $50 billion over 5 years, $10 billion a year. Have you looked into that program and have any visibility to that as to what's going to happen?
Yes, we have looked into that. That is a very huge opportunity across every state, and that's going to impact so many people. You're opening up a very large door of a conversation. I'll try not to go too far down that rabbit hole, but yes, there is a lot of opportunity for states to use this funding, and every state right now is trying to figure out how best to implement that. Everybody kind of has a similar vision based on the rules that CMS put out there, but every state has their own nuances that they're trying to figure out how best to deploy those funds. I think hopefully in a fair and equitable way across their state. And Mississippi is no different in that. And I think that the things that we're seeing is some are more transparent than others, and some are getting some of their applications out there. So I would challenge, or not challenge, but I would hope and encourage everyone to get out there and start looking at their states and looking at what opportunities there are from funding opportunities that all tie back to chronic disease management and all of the different types of services that we're talking about here. There is a large amount of money to go after and do that. And so I think one of the key features of that is going to be partnerships. I think it's not going to be just one hospital or one vendor or one provider group that's going to go try to tackle chronic conditions across our state. It's going to be big partnerships. You're going to need other people to help, and I think that's where from what I'm seeing across some of the different states, that's really what they're looking for too, is some of those partnerships to really maximize their impact across their states. So,
Got it. Got it. Yeah. You see, one of the key elements of it is technology, to use technology as part of the solution. So it seems like, your position right there with your RPM telehealth program to get involved, right, in a big way. So, yeah.
yeah, when all of this came out, it was we felt like they were talking to us. It's kind of like, well, we've been doing these things for a long time, and so we feel like we've been preaching for a while, and now they're finally hearing us, kind of a thing. And so it's very exciting and encouraging. And we're a national center of excellence, and so we work with groups across the country in different capacities, large health systems to FQHCs, and literally across from Hawaii to New York. And so just being able to see how people in different areas are all asking a lot of the same questions and getting a little bit of more answers, and a little bit more answers, and a little bit more answers to try to figure out what best fits them in their environment. So it's like I said, it's kind of the same ideas, but you just got to make it work for your own area there.
Terrific. Great. Thank you. Appreciate it.
This is Joe McManaman. I've got a couple of questions as well. I guess the first is for both of you. Can you cite me to what you consider to be the best literature demonstrating either effectiveness or cost effectiveness of both of the RPM services you've been describing? And the second pertains, and I guess that literature could originate either at UMMC or any other organization you respect. And the second question might be Carly specific, in that she mentioned utility of this approach in management of, among other problems, COPD. I'm particularly interested in literature demonstrating effectiveness and cost effectiveness in COPD, as I've recently encountered literature that challenges that proposition. Thank you both.
Carly, I can tackle the cost part, and then you can take the rest of it if you want to do that. I find it challenging for the cost value effectiveness of it as well. So that's why, and I think the challenge with that is that it's so variable based on what services, what your costs are, where you are, payers, your local payers, who's paying, who's not paying, and all of those there's so many different variables, so that I could say, yeah, it works great here. I could be in Iowa and say it doesn't work great there. And so the main thing, and then you look at vendors who may say that, oh, here's the additional revenue that you can get for your program to do it this way. I see a lot of different stories as well. And so I think I share in your sentiment of trying to find that source of truth into, does this work? Does it not work? I think every area, every group has to kind of do their own due diligence based on what information is out there to say, here's expected costs. Here's what I know it takes to run this thing. And here's for this type of patient population. And then based on what types of services I'm providing, what are my local payers? What's my Medicaid going to pay? What's my commercial payers going to pay? And then Medicare is obviously, I think, kind of the most transparent, stable payment model out there that you can look at and get some kind of idea. But at the end of the day, you kind of have to run a cost model based on where you are. So I don't have a good source. I wish there was. Heck, if someone on this group knows of one, I would love to hear about it, to be honest with you, because I feel like it's such a decentralized approach at this point to try to solve that problem. But that's from the cost model perspective. Carly, you got anything from the rest of it?
Yeah, great questions. And I would agree with Kyle. I think the literature is highly variable on all of those things. And And us internally on the work that I presented, the clinical research part and our clinical outcomes, those manuscripts are all currently in preparation or under review right now. So I hope to have some publishable results soon for you. I will say our original diabetes and hypertension pilots, those have been published papers, and I'm happy to send you links to those if you'd like to read them and get more information about our workflows and outcomes and things like that. But hopefully more to share soon from those papers, specifically COPD and taking a deeper dive into our kind of long-term implementation of our programs.
Thank you. Yes, I'd be happy to see papers on the diabetes and hypertension. COPD sticks out for the reason I mentioned. I've come across pieces recently arguing that whatever value RPM may have in other settings, COPD is just not on the list of diagnoses for which this is effective.
Of course.
Any other questions? Great. Well, thank you both so much for taking the time to speak today. We really appreciate you sharing your insights with folks. This webinar recording will be made available. We'll upload it once it's processed and ready, and so that will be available as well. Again, thank you all so much for joining us today. I hope you all have a great rest of your day.
Thank you.
You
Thank you.
Thanks.